So in broad terms, there is invasive breast cancer and non-invasive breast cancer. And the non-invasive or the pre-invasive, it's the early type, early changes. At the cellular level, the cells are cancer cells, but they have not started invading through the tissue. It's what we call DCIS. And usually the treatment for that is completely different than invasive breast cancer. And invasive breast cancer is different types. The commonest type is invasive ductal carcinoma, and the second commonest is invasive lobular carcinoma, and there's some other types. It's not only the type that's important for invasive cancer, also certain hormone receptors and other receptors we check on the cancer are very important in planning what is the next step, what is the best treatment for you. So let's start talking about non-invasive cancer or DCIS. In theory, this should not spread. So in theory, we start with surgery first. If it's a small area, usually we can do a lumpectomy. If it's a big area, sometimes we end up doing a mastectomy, with the understanding that there is about 1 in 5 or 1 in 6 chance when we do the mastectomy, you might find invasive cancer because the biopsy has told us only about part of the equation. If the patient has a lumpectomy, most likely they'll end up having radiotherapy. What is more complex is the invasive cancer. And what's important for us for the invasive cancer, it's not only the grade and not only the size. The hormone receptors are very important because we can't target our treatments. The most two important receptors for us is the estrogen receptor and the HER2 receptor. So if you think with me, the majority of ladies have estrogen receptor positive, HER2 negative breast cancer. The majority of the times we start with surgery first. That does not mean that they do not need any chemotherapy or any other treatments. They still might need it, but sometimes there is no benefit from starting with it, except in certain selected cases. While if the tumor is estrogen receptor negative or HER2 positive, that's slightly different. If the patient has, for example, estrogen receptor negative and HER2 negative breast cancer, especially if it reaches that 2 centimeter size, then starting with chemotherapy along with immunotherapy is the first step of the management. If they're HER2 positive, regardless if the estrogen receptor is negative or positive, as long as the tumor reaches that about 2 centimeter size or if there's any abnormal lymph glands, also we start with chemotherapy, joining that with some anti-HER2 treatments, which we call Herceptin, or most likely will be Phesgo, and that will be the first step in their management. After that, they will have the surgery, and the surgery will be adapted according to their response. After that, if they kept the breast, they'll have radiotherapy. If they had a mastectomy, some ladies will need to have radiotherapy, not all of them. And there's some other treatments that come into the equation, so it's more a complex process. Decision-making comes in an MDT, where we have the surgeons, radiologists, pathologists, medical oncologists and clinical oncologists meeting at least once a week and discussing the patient's details and discussing all their management. Of course, there'll be input also from the breast care nurses and other specialties.